Usually I like to walk around a large room, so I'm sitting virtual with a couple of girls here, and so I will try to bring you my passion for education. So we're going to talk about surveys. If you've never been through a survey, you're going to listen hard. If you've been through a survey, it could be some validation, and I'll give you as much information as I can to make you aware of what a survey does. You don't need my bio. These are some of the acronyms that we are going to use today. Everybody uses something different. We say Medicare deemed status. It's a CMS, your state operations manual. Every state has their own Department of Health, DOH. Your POC is what you would get after a survey from either your state or from one of the accreditation agencies. And they will talk about if you had a condition for coverage, if you were non-compliant, if you were partial compliant, and if you had a deficiency, which I call tags. So that's what this is about, is having not have any deficiencies. And the speakers earlier today talked a lot about life safety. So we'll cover a little bit more of that. The accreditation organizations that we were talking about that are going to come out and do a survey for you is AAAHC, Quad A SF, the Joint Commission, HFAP, and IMQ. There may be a few other accreditation agencies that are out there doing this, and we will keep you updated other than if there's anybody new coming. All right, these are the really hot topics here that a surveyor is going to talk about. You've probably been hearing a lot of this because they don't seem to change. One of my favorite pictures here is two things. One, you can guess that that cord is not rolled all the way down. It's supposed to be 1 inch from the floor. So if someone were to fall, you would be able to pull that. And the second is there is an air freshener in there, which is fine. Understand, as long as you're not using it as a disinfectant, an air freshener, the center would need to have an SDS sheet. That's the safety data sheet. So in case we spray it, have an allergic reaction, that's why we would need that. So getting right into patient rights, my favorite. Here's where we're going to talk about the advance directive. Patients are allowed to come with their advance directive. Oftentimes you're going to know that ahead of time. However, it needs to say in your policy procedure or somewhere very specifically that your ASC, since you're not a hospital, you will accept an advance directive, make a copy of it, you will give it back to the patient, keep a copy in the original goes back to the patient, a copy in the chart. However, that's when the patient needs to be informed that the ASC does not honor it. And what does that mean? It's important. We usually like a nurse to tell this to one of the patients so that they understand that if something were to happen to them at your center, that the center's responsibility is to do a stabilization and a transfer. At that time, their medical records with their advance directive would be for the hospital to then put that into use. So it's very important that we have this information. And one of the things that we're asked to do is give patients advance directive information. The goal is not to have them fill out an advance directive that day. Is they need to understand what their rights are in your center. The other rights that we're going to talk about that is a big tag is a physician disclosure. The physician disclosure was put about several years ago. When you went to a big hospital, you did not know who the owners were and who ran the center. Surgery centers are much smaller. We have dedicated owners. Sometimes it's management company and they'd be partners with physician. So CMS requires you to disclose on your website, in your waiting room, and in your patient packet who the physicians are who are owners. If you choose to denote this, where you have regular physicians and you want to denote it by a star, letting them know who that's your owners, that's totally fine. The patient has a right to say, hey, I don't like my next door neighbor. Oh, he's a doctor at your surgery center. I don't want to give him money, so thank you, right? Something like that can happen. We also want to be sure that there's not a physician referral, so that this way everybody has the right to know who the physicians are that own in that center. If you're not posting this, you can get in a HIPAA violation in the sense that you're supposed to give all this information to the patients. So don't just say that upon asking, please make sure you have a physician disclosure posted. That will be looked for. We're also looking for the no smoking sign outside of your building and in your waiting room. If you want to put other things in there that you don't vape, etc., but you must have a no smoking sign. The staff ID badges. So this has come up a lot lately, and the staff is required to identify themselves and their role in your center, right? You do not have to put full last names, right? There's a lot of times that we talk about that you don't want somebody to know your full name. We've talked about some of the times nurses get, oh, I want to take you out, or, oh, you did such a great job. So as long as you have a first initial last name and what the title is. So if you're a surgical tech, you would expect to see surgical tech. If you're the director of nursing, we would want to see that you're a director of nursing. And the second part of that is when I go into centers and I go in and I say, where's all your name badges? And then somebody will open it up and say, oh, underneath here. So what you really need to tell the staff is if they're going to wear a lab jacket, that they have to wear it on the outside. It must be identifiable at all times. So if you do not do ID badges, you would need to start that. And that would be coupled with your visitor log. And your visitor log is very important to a surveyor, as it will be any life safety. Your visitor log is not your patients. These are people who are coming into the center who are not with your patients. They are, maybe you're having your biomed folks come in and do your PM. They should sign your book. They should say what time they're here. They should be given a visitor badge. Some of the centers I've been working with, if they have a rep that's going to go into the OR or someone that's in the back doing preventive maintenance, they have been giving them a red bouffant. And it's a great safety feature so that when somebody's in scrubs in your center and you see a red bouffant, you automatically know that they are not part of your center, they're extra. So if we had an emergency situation, we can pick somebody up quickly. The visitor log also acts as a safety mechanism, whereas you're going to have a disaster, you're going to have an issue, the nurses know to grab the schedule of who's discharged, and the front desk is going to take that visitor log and make sure that everybody was signed in and signed out so that we don't have a miscellaneous person in the building during a crisis or a disaster. This is where the next one, Dan left, otherwise we can talk about law, the responsible adult. This has been under, I want to say, controversy and up for discussion for years. It's probably never going to go away. The rule states that if you are having anesthesia, not we're talking about local, we're talking about if you've been given anesthesia, you must leave the center with a responsible adult. A responsible adult means somebody over the age of 18 and somebody who is going to be driving you. So what we have seen oftentimes is, and I'm sure you're all going to laugh in your office right now, how many times they say, oh yeah, my ride's right outside. And you step outside and one of the nurses go, guess what? He just got into a car all by himself and drove away. So one of the things that we change in our patient rights is to be sure that we are walking or wheeling, depending upon what type of anesthesia, the patients to the door with a staff member. It does not have to be a nurse, but don't let them get out of your sight without wheeling them. Because at the end of the day, I talk a lot about court, at the end of the day, if a patient were to fall and they're just with their responsible, you have not discharged them properly to their ride, right? So we want to be sure that there is a responsible adult. If for some reason there is not a responsible adult, you're going to try to do all of this preoperatively, ask who their ride is, etc. Here's a little trick for you that might help. Is if they say they come to the center, now they're here for their endoscopic procedure, they can get dropped off, right? And a responsible can be told what time to come back and get them. So now it's time for them to come back and there is not a responsible, okay? You don't want them to go home in an Uber. You do not want to call a cab because you're not sending them home. So you have two things you can do. If you really truly have to send them in an Uber or a cab, your physician must then write an order. Okay? You cannot just discharge them against your policy, which is an order. So the doctor then would have to write exempt for going home with a responsible adult. Now the physician is taking responsibility for that patient. Okay? You have one more little trick that if a patient really says to you, I don't have a ride, I thought she was coming. And one of the other things, especially if it's through their insurance company, that you have a right if they are going to leave against medical advice, which is if they're going to go home without a responsible adult, understand that you can say to the patient, because we have a contract with your insurance company, we have to let them know that you left AMA and therefore you may be responsible for the whole bill. And how many people find somebody to come pick them up pretty quick? They really do. So that's just a little tip that I like to hand out to all of you guys. HIPAA. The surveyors do come into your center And I'm going to say to you right away, they're listening for voices, how loud things are, can they overhear? When they're doing their walkthrough in your area where you have your patient bay areas, right? You're not having separate rooms. We all know they're curtains, right? We want those curtains to be pulled all the way so that you cannot see someone else. We know that sometimes that you want to put two nurses there, maybe you have a nurse on the other side. You have to do what's right as far as patient rights. So we're going to pull their curtain. We're not going to leave a patient alone. If we're handing them a call bell, we're going to explain to them, make sure that they have an understanding of how to use that call bell. And we're going to use our quiet voices. And there was a couple of the surveys that I have been on where the surveyor talked about very specifically, I can hear what's going on the curtain, on the other side of that curtain. And so they felt that they were not protecting the patient's rights through HIPAA. And their plan of correction, they bought one of those white noise machines. And so therefore it muffled the noises, and they were showing they were making a great effort to reduce that. They also do not call the patient by their first and last name. We can call the first name, last initial. There's a lot of products that are coming out there now that we have case tabs and some of the others where it'll just put where the patient is so that somebody can have an idea of where their person is. So the last one on here is grievances. Okay, so grievance is a little bit tricky, and you are required to have a grievance policy. You are required in your patient rights, and this is the last page of one of my patient rights. These are what you are required to have so the patient has a right to do questions and complaints. You can't just put down administrator. You must put down your address and any contact information, phones, faxes, emails. And then on the bottom, you must also, if you're a Medicare participant, you must give them by law all of this Medicare information. Lastly, I did not put this on here. If you have an organization and you are credited with AAA, let's say, you will need to put the AAA information on your patient rights as well and who they are allowed to put a grievance in with. So let me just tell you briefly about a grievance, because a lot of the centers that I've walked into, and by the way, I've done about 90 CMS surveys and 500 mock surveys. So when I walk into a center, I do ask, tell me about your grievances. And a lot of them say, we don't have any. Well, I think that's impossible in my mind is what I say. I said, has anybody ever complained it's really cold? Of course. Has anybody complained that they weren't told that the doctor was running an hour and a half late? Of course. Has anybody been told that, excuse me, that they were to bring certain things with them, right? So if a person is going to have a grievance, first thing you need to know, if it has anything to do with money and finances, it is not a grievance. So if they complain about a copay or money, it gets directed to the right department. That is not a grievance. A grievance could be, many times, I couldn't find your center, had to travel twice. Maybe you're getting several of those grievances. So you would want to document it, even if it's anonymous, you want to document it because you still want to be able to show what are you doing about this. So if I get lost and I go to centers often, I often say to them, did you have that as a grievance? And they say, oh yeah, all the time. And I say, what are you doing about it? And they said, not really anything. So when you have opportunities to change things, it is up to the center, the leadership, and the governing board to make sure that patients understand their rights and have full, ample time to do a communication of a grievance. So if you're told as a nurse, you're sitting there with your patient and you're getting ready through discharge, and maybe the patient now says, you know, I was stuck twice before an anesthesiologist came and started my IV. And you know what? In that particular grievance, it was a couple of days later, the office manager, the administrator called the patient and said, thank you so much that we actually just bought a vein finder. And our policy will be if someone is a hard stick, we're going to use the vein finder and we can go straight to anesthesia. So in that case, we took a grievance and we turned it around to let the patients know, thank you, right? Patients aren't just complaining to complain. Well, maybe some are, but for the most part, they want you to do the right thing. They want to know that you're hearing them and they're heard. So grievances, please don't say that you don't have any. Grievances can come in from your staff and your physicians also. You'll log them in a different part of the book because you have patient and visitor grievances and your other grievances are separate. So this is your patient rights, and this was in one particular waiting room. By the way, when I show pictures, it never identifies your center. So if you know it's your center, it's only because you work there. So to the picture where you see the young lady sitting there waiting, there was nothing up on the wall except for artwork. People need to know you are required to have certain documentation on your walls in sight in your waiting room where the patient can see it. So in this particular one, there was a tag because there was zero information. There was no patient rights. There was nothing here that was required. Then about 2 feet away, as you can see, there's a rack right here. And I said, what is this rack for, with cardboard boxes, again, sitting outside the center? And they said, this is for our deliveries. Please, people, you're going to have deliveries. You cannot have syringes there. You cannot have medication. You cannot have liquids. Therefore, this is an unsecured. If a surveyor saw this, this would be a jeopardy because they were returning syringes and some medications. So pay attention where you're leaving things. Your staff should be educated on what needs to be secured and unsecured. The last one, also in the same waiting room, was, this is during COVID, of course, so they took water coolers out of use, which I think a lot of centers did. And the rule of thumb, when anything is not in use, whether it be broken or in this case, not in use, we're going to tag it just like it's tagged, but we're going to remove it. And we don't want to leave things in service. So if you're in the OR and your bear hugger isn't working, you don't want to leave it there thinking that you're going to be able to plug it in. So when we put things out of service, our name, our initial, our date, and move it to where somebody is going to know it is truly out of service, and be sure that we're going to report that to our supervisor. So this waiting room was a big fail, and they're going to be correcting all of this. All right, so the next hot topic, of course, is the credentialing and governance, which I do a whole program on separately. So I will just give you the highlights of what is missing. A surveyor is going to come in. If you haven't been surveyed, they're going to ask you for your staff roster. They're going to ask you for your physician roster. All leadership should have this current, even if you assign this to someone else. If somebody is missing anything in their file, make them inactive. Do not let them book a case or work until they've returned these documents to you. Saying that they were supposed to bring in their new certification is fine, because you're going to go online and you're going to do the verification. And the first line here says verification's missing. So when a surveyor comes in, years ago, we would take everybody's license, their CDS, we took that. We don't need that anymore, right? What we really need to know is we go on to a verification site, and that's the printout that we want to see, okay? So that's the verifications. We have OIG, which is the Office of Internal General. That's if anybody was involved in any type of a Medicare fraud. We do OIG in most surgery centers annually, and we also do that for our vendors. The reason that we do that for our vendors is you do want to know if they were involved in any Medicare fraud and billing, because you run an OIG, it would tell you whether there was any reports. The next hot one is not following your privileging policy. Each center is able to, through their bylaws, develop the credentialing program. In AAA, I believe, and Quad A, you can have your credentialing period 36 months. You can give your initial person 36 months, and you can re-credential for 36 months. In the CMS guidelines, it says 24 months is recommended, because we have not had those updates made. Just to let you know, if your accreditation allows you to do 36 months, it's something to think about. It's time and money. As we all know, to re-credential, some of the centers have 68 doctors, and to do that every 2 years is certainly timely. So you want to follow your privilege policy, and if somebody's term is going to expire June 1st, you best make sure that you have started them on June 1st. You do never want to have a lapse. You can put it the day before, okay? So you do not want to have any lapse in your credentialing for your policies. Also, your physicians, your medical directors, your alternates are supposed to have job descriptions in their files, just as any employee would be. So people ask me this, why? Well, because sometimes positions are just handed out, and sometimes they don't necessarily know that they have this position. Therefore, they're signing their job description. They know they're the alternate medical director, what their responsibilities are. So please be sure that you have all of these signed and in the provider's charts. The other hot one is privileges. So when somebody comes to your center and they put in an application, you're going to give them a privilege list that you have approved privileges in your surgery center. Understand that a provider who is denied a privilege has to report that. So what you really want to do is be sure that your privileges are specifically what a surgery center is allowed to do. Then you're going to take the provider's credentials. He wanted to do X, Y, and Z procedures. you will get your hospital letter and the list of procedures that they are allowed to do in their hospital. As long as they are privileged to do it in the hospital, most of the states are accepting that as that, right? They don't have to necessarily do a shadow, or again, if it's your policy, first day of a new provider, he may be shadowed. But you do have to have the privileges that are requested and they are approved. So try not to do something where it would be a denial for someone, or be sure that you would send it back to them for a denial. The reappointment, okay. So everybody comes the very first time, you have that nice thick application. A reappointment is due for them to fill out, for your providers to fill out. It's a little bit shorter form, but it is still long. However, you are allowed to do copying for them or have their office manager do that. You're just not signing it for them. They are required to read and attest to those questions, and they are required to do that. And upon a reappointment, not only are we expecting to see the application, but you have to re-credential them. So you're going to go through your AMA, you're going to go through your National Physician Data Bank, you're going to do all your due diligence as if they were a brand new person as far as all of your credentialing. Your peer reviews are the most important, and a lot of the centers who, I call them the one-room centers, mom and pops, you didn't necessarily know that you were required to do a peer review. So what peer review really is peer-to-peer. So if you are a pain center and you have 6 pain doctors, each one of them has to have random charts reviewed. Each person isn't required to be the reviewer. Some policies, some of your centers may have one dedicated person who really likes to do the peer reviews. You can do it however you want. It could be quarterly, it can be monthly. The rule of thumb is usually 5% of the charts per provider. And you can just do a list of questions that the other provider is going to fill out. And if there's issues, you have to stop and remember everything can't be perfect, right? So we want to put something in there. Maybe it's a doctor who doesn't have his H&Ps timely. We want to put that down as part of a peer review. Maybe it's not detrimental enough not to re-credential them, but it may be something that we have to have a chat because your charts are due 30 days to be filled out. So the governance. So if any of you have had a POC, this may be exactly what you say, where it says this condition is not met as evidenced by Q040. And this is exactly what your governance is supposed to take care of, right? So the governing board, you may have a center of maybe 5 doctors. You may have a center of 2 doctors. It really doesn't matter how many you have. You still need to have a governing board who is going to show that they have the oversight of what was happening at your center. So what happens here is maybe you had a tag in pharmacy. Maybe you've just had a tag in infection. So please understand that you're going to now be tagged in that in the infection chapter, and then you're going to be re-tagged for it in governance, because anything that was a tag that the governing body oversees, you have to show that they have oversight and you didn't. So therefore, you're going to see quite a bit of this. So when you get tagged, sometimes in several categories, and what will save you on that one? This is where it will save you, is to make sure communication. So if you're a small center, you may say, I talk to my doc every day. Understood. That's fine. Have your quarterly meetings. You're not required to have them quarterly. It is highly suggested. Small centers sometimes do them twice a year. And you want to document, okay? Your minutes are what tells your story. So when I go into a center, I like to see minutes ahead of time. The accreditation organizations usually ask you for your last 2 sets. It tells a little bit of a story. How are you communicating with your governing board? So your annual minutes, you must document that. Again, maybe you're saying, oh, we approved everything. It's great. The nursing rule of thumb is if you didn't document it, it didn't happen, right? Annual minutes are required. Your governing board, just everything that you do, even if it's a quality study, how are you letting your governing board know what's going on? In your quality slides, you may have gotten a ding in quality because, again, your governing board has to oversee this. So every time you do a 10-step study, you start a study for a reason. Maybe it's just a benchmark or you have an issue, excuse me. You want to put in there, how is this reported to the governing board? Is it reported during your meetings? Is it reported how, right? We just need them to know that you're opening a study and why. And the last one is your privileging guidelines and bylaws. So if, again, you're going to do a credentialing, maybe you credential only every quarter, We want to say, then the last one, applications were sent, we're in review. You want to tell a story to what your physicians are. When your center has approved all of them, again, it's in the minutes so that your board members know who is our new person, what specialty, and what time period will they be effective in our center. This is one of the other requirements that I just made a little easy chart that not only do the surveyors want to see, it's really best if your team wants to see it. Sometimes you have one or two directors of nursing with alternates. And so maybe you do it by day. Maybe you have a director of nursing Monday, Wednesday, Friday of this person and another one. So this is where it's best to post this near your front desk and in the back so that if somebody does come in to walk in for a little visit for you, you know who everybody is. Sometimes they're per diem, so we post this. Right? In New Jersey, we have a little bit of different regs. We are required to have an outside pharmacy consultant who has to come in twice a year. And we're also required to have infection control consultants. These are outside people who have the qualifications to do that. So what they're looking for inside is who is your infection nurse on your premises. So that's very important. And that's where you'll see it says the center liaison. Who is in charge of looking over the infection? Does she have a job description? Is she identified? I have walked into a couple of centers and I said to a nurse, who's the infection person here? And they just point and the other woman says, yeah, I got it by default. I said, have you been trained? She said, no. So it's really important that, again, when titles and positions are given out, they need to be accepted. They need to have job descriptions and people really need to understand what it is. Because we're going to talk about the leadership roles. Whoops, sorry about that. The leadership roles, I'll speak this way. The regs say, right, you're supposed to have an administrator and you're supposed to have a director of nursing on premises when you're having cases. In some of the instances, the center is very small, and we certainly understand a nurse can become an administrator / director of nursing, which is fine. She will have an alternate, sometimes two different people. Maybe she'll have an alternate just for the administrator, a separate person who's her DON. It may be another person. What you do need to understand, and your physicians and board really need to understand this is, if you're a director of nursing and you need to go in and do patient care of any kind during that day, your alternate must be immediately available. Okay? So if you're doing a lunch break and your alternate is going to have lunch, she is immediately available for an emergency situation. So I just like to clarify the two things. But if you are the director of nursing and you are in the schedule, which remember, they're going to ask for a couple of weeks of your schedule, you're going to just be in trouble right there because they do not want you in patient care for any reason unless it's an emergency. So I really can't stress that one enough. Your safety officer and your fire marshal also varies from state to state. New York requires you to go take a test and get a little bit more. However, somebody needs to be designated on site and they should absolutely know this and review this upon orientation and during annual education. Okay, pharmaceuticals. I have a lot of pictures coming for this, but the hot topics here, I call it scrub the hub. And when I walk into your ORs, and this is what I want you all to do in your round, they're going to set up with vials, right? And we always talk about it, right? One needle, one syringe, one time. Well, that also means scrubbing the hub each time. Scrub the hub is your alcohol wipes. And there is no set time. Somebody said 15 seconds. You scrub the hub, and what you're looking for is to create friction. Not fiction, friction. So scrub the hub, you're doing that with an alcohol wipe. If you're going back into that vial, you're scrubbing the hub again with another alcohol wipe. So when I walk in and I see things set up, I expect to see a lot of alcohol wipes and they weren't there. So it's telling me we're not happening with scrub the hub each time, okay? If your doctors are in a hurry, you're still gonna say, hold on, it's an extra second, okay? The refrigerator monitoring is one of the other tags. A couple little things you should know is the refrigerator thermometers that have that 24/7 calibration, which is great if you can get an alert as long as you know how long, what the temperature is if it's out of range. However, these also expire. On the back of your measuring of the thermometer, take a look at it and it'll usually say it expires. So if a surveyor comes in, even though it is still registering correctly, if they find it's expired, they're going to tell you that you have to get a new one and that your data may not be correct. So refrigerator monitoring, awfully important. If you have a staff refrigerator where it's food in your kitchen, you don't have to monitor that twice a day, right? Because we don't have vaccines in there. However, you're feeding your staff. And if there's mayonnaise, if there's et cetera in there, you do want to know if it's gone through the temp. Often staff refrigerators are not on the generator. Your formulary. Formulary is very important and probably was set up when you first started your center. Hopefully it is reviewed every year. It's an important piece. The formulary is going to talk about things that may be recalled, that might have back order or are not available anymore. Or sometimes it's a drug we haven't used in 10 years and it's still on your formulary. So that's showing a surveyor that you have not had governing board approval. They haven't looked at it. So if you have not done so, have your pharmacy consultant and or anesthesia, usually they're great, is take a look at your formulary and be sure what you have is what you're ordering. Before I forget, I do want to tell you in your code cards, this has come up a couple of times, for expired medications that must be in your code card. And there's two ways of thumb to think about this. And again, governing board must give this approval. You may put your expired medication in the code card, labeled and tagged expired governing board approval. You will have your minutes that are going to say on this date, this was still back ordered. We have expired medication. The governing board has decided to leave it in the cart, all staff available. So when a surveyor does indeed come in and finds you with an expired medication, your answer is our governing board would rather have expired than have none. And you can say that it's in your minutes. To skip labeling syringes for a minute, but your multi-dose vial is still happening. And I understand we're going to talk about, right? It's money, saving money. It's ridiculous. It's a rule and it's a reg. So if you want to use multi-dose vials, you must have a medication draw area. That is a separate area from patient care. Often it's an anesthesia room, it's a prep room. It cannot be out in the open where your patients are. You also cannot do that in your OR. So if you're bringing in multi-dose vials in the OR, considered a patient care area, it can be used once and it must be tossed. And I will say, as a mock surveyor, I do look in the sharps to see how many might have been in there. And I do take a peek, and there are several vials missing because they've been used as multi-dose. So keep that in mind. The 222 form is also really important. The surveyors are really looking for your purchase order, who ordered the drug, when it's delivered, who signed for it, right? We're going to attach all of that together, and we're going to make sure it's counted in inventory. The person who is ordering it and signing for it should be two different people. And we have two witnesses, of course, for the 222 forms. Hold them, keep them in order. Do not rip them. What you're going to do is just write the word void on it. So now we're going to go into the labeling of syringes. So these are real pictures. So there's a couple of tags that you're looking for right here. So what are we supposed to do when we have a syringe that we're not using immediately filled with medication? It must be labeled. Must. There's not even a question. And when we drop a medication, the length of time is only good for 60 minutes. So your drug name, the strength, the date of the preparation, your time. You can use a beyond use date and time, and the initials of the preparer. You can see here we have propofol. There is 0 labeling. This particular center was going to have 6 cases in an hour. Okay, so they told me that that's why they were drawing up so many syringes. If indeed, maybe you really are going to have 3 or 4 in the hour, and you can do that, again, label it. This is not labeled, okay? You're also going to see to the left, your Diprovan, again, not thrown out after, okay? The last tag in this picture is where you see the key box. A narcotic box must be double locked. One, it must be bolted to the wall, secured, adhered. They use the word bolt. And then you would open it up and you would find another block. So it could be in your cabinet. So you would unlock your cabinet and you open your cabinet and you will find this that needs to be secured. Okay? Some of the anesthesia carts have this secured inside. It would be the same thing. All right, just a couple of my favorite little pictures. So rubber bands don't belong in a surgery center. Orange and blue rubber bands are latex free, understand that. But anything you put a rubber band around can possibly compromise what's inside of it, right? I have a couple other pictures. One to the right is where I walked in, and on the back table, you're going to see there's a multi and another multi, and there's no alcohol pads here. So we had a nice chat because it was the 6th patient of the day, and it was their first bottle of lidocaine. A couple other favorite pictures of mine. Here's another one of the lock boxes. Again, they had 1, but they didn't have 2. So They got a tag for that. Then when you look at the saline, you're going to see the date, but it did not have anything else. Also a requirement. So when you're doing your rounds, folks, especially if you have some new leadership, new nurses, take a look and see what they're doing. The expired, like I said, we were using that for training. They, in the right direction, expired Rivanto, do not use, and we need to date it and put initials there, okay, so that we are saving it and nobody touches it. The last middle picture is just showing another shelf how we should not be storing things mixed up. You have some sterilized trays, you have some medication, and this was also not double locked. A couple more hits in the pharmacy area is if you have any of these top of the cart holders, as I call them, be really careful not to put any syringes in there because these do not lock. So when you go into a survey, I often see these, and you do need to make sure that there's not a medication or a syringe in there. That is a tag for not securing it. To the right, you're going to see there's formalin containers. Formalin is a biohazardous material. You should have a spill kit. It either covers formalin or a universal spill kit. And formalin should not be just sitting on a tray like this. Because it is a hazardous material, the best way to have hazardous material is in a container or a drawer where it can't just fall out, it can't slip off of a tray, and it is to be marked biohazard. So this way you're letting everyone and anyone know that formalin is a biohazard and we're taking precaution. Also, on some of the formalin containers, they have expiration dates, so you do want to take a look at those as well. Okay, medical records. It doesn't matter whether you are EMR, right? You're EMR or your paper charts. So the surveyors now have been getting very used to, just so you know, your EMR. So in the beginning of EMRs, it was great. And we thought, oh, they don't know how to get through the system. They don't know our system. Well, they're learning our systems. And after one or two little shows, they usually will have you leave them and they want to go through your chart. So there's a couple of things I want to talk about there if you're an EMR. Understand that there's an audit trail, okay? As leadership, you know that you can look for an audit trail and you can see what's there, who did it, who made a change. Remember, anything that is added after the procedure is called an addendum note. Okay? It's really important that we have that. So that's going to happen in an EMR. In a paper chart, right, it's legibility. When we're doing some of these chart audits, one of the questions that we ask somebody who's doing the audit, is it legible? Some of your doctors are great, but I will say to you right now, if you're doing a chart audit and you can't read 3/4 of that handwriting, that has to be addressed, because therefore we understand that the doctor knows it, but nobody else can translate it, and that would have something to do with when they're going, if there was a transfer or medical records are sent. Remember, medical records are sent if there's any lawsuits and types of hip injuries. So the legibility is really important. The storage and privacy, one of the first questions that a surveyor will ask you is, where are your medical records kept? And most of the answers are correct, and it would say in a locked medical record room, and they are in metal cabinets inside with sprinklers, right? That's what they're looking for, to be sure that they are adhered for and secure. And in your emergency prep, you should have something going on where you know how to secure medical records in the case of an emergency. The chart audits, there is not a regulatory standard of how many or what you should be doing. A rule of thumb, similar to a peer review, is how many patients are you seeing? You want to capture what is really happening in your facility. So the person that is closing your chart, maybe sometimes it's front desk or it's given to someone, that person should not be the person who's auditing. A separate chart audit should happen. Maybe you're going to grab 20 of the charts from 2 months ago. Remember, you have 30 days to close your chart, and we're going to take a look at those audits. Somebody should be tracking it. And again, nobody's expecting it to be 100%, not even a surveyor. What they want to know is if there's a trend or a pattern, what are you doing about it, okay? The medication reconciliation forms seem to be a little misunderstood. And so let's just review that. Every single patient for every single visit to the center is required to have a medication reconciliation and leave with a copy of this. This was put into effect so that the patient would be able to take this type of a form to any of their physicians and understand what was given that day. So medication reconciliation is required. It's also required anytime it says the word allergy, you must have the word reaction next to it. So at this point, if you have those stickers that you put on the front of the chart and they don't have that, your best bet is to get an allergy reaction label, or you're going to put a label for each one of their visits where you ask them allergies. You are required. The medication reconciliation form is going to have that. You are required each time to ask them the questions. Maybe they're bringing in the big bag of medicines for you. You're allowed to make a copy of that reconciliation and redate it, okay? If that's easier for the center. Some of the pain patients come in every 2 weeks and they're going to say, I have to go through this, and you're just reviewing it with them. And lastly, on this one is the discharge paperwork. Patients will be discharged, right? Sometimes they are still a little bit under anesthesia. I don't know what happened. I think you guys can still see me. So if they're under anesthesia, they're still going to have their discharge paperwork. When you're discharging them, be sure that you're saying all of your discharge paperwork is in this envelope. Some of the centers, just like the red bouffant, are using it as a red envelope. And they're saying, remember that red envelope? Oh, yeah. So be sure that you have a way to ensure that the patients are getting their discharge paperwork, because it must have the instructions on what to do if there's any symptoms. And the last one in medical records is the #1 tag that you are missing, time and date. I would say on 60% of the forms, unless you're electronic, of course, but time and date, if you're going to put the word time and date, expect it to be filled out. If you're doing pre-op orders, folks, you're going to have a nurse who maybe is taking a verbal, maybe it's part of a standing. Her time and date is going to be there, and then she's going to do a readback if it's a verbal, and that has to be on there too. So I would say that's the #1 thing when you're doing an audit, put down to make sure that time and date is there on all of the forms. So these are some of the tags in medical records. We just talked about orders, and the provider was signing offers after the nurse gave an IV. So one of the things that we want to do is you either can do a verbal, or if your center is, the nurse is always giving the same thing, get a pre-written order and have your board approve it for each one of the doctors of what their order is. Okay? The other thing that's missing in a lot of the charts is if your patient had an unfortunate reason to be transferred, that physician must write an order to be transferred. And there's a couple of places that I've been into, they fill out the discharge summary paperwork ahead of time because it's easier for the doctor and it's never been an issue. And when that happens and that goes in the chart because you have a transfer, it really shows that you're not doing your due diligence and making sure these are filled out afterwards. So you must have an order for a patient transfer. And the discharge, you also need to have on there is the phone number, who they should call. And if you're telling them to go to call 911, if it's an emergency, you need to define what an emergency is, right? Whether it's shortness of breath, or if you can't reach your physician, you must be very specific in a discharge. The other one is your pathology. A pathology report, just like your COVID is a test, and pathology must be signed by the physician. Nurses may review it, and you may have policies and procedures of what to do with that. However, that pathology, each page must be signed and dated, each page. And I want to throw in here that this includes COVID testing. If you have a result from the test, right, same thing as a pathology, the provider must initial the COVID test and date it. So this seems to be a hot one, but that's what you need to do. Post-op. A lot of the centers are really taking the time to do this because we have all different texting or messaging systems, but we are looking to call the patient 2 times and to find out how they are. Maybe the physician calls that night, and therefore that would be one of the calls, but be sure that you have his documents of what the patient said. So we're looking for 2 times to give them an opportunity. We used to write a lot of letters. That stopped now, again, for the messaging. There's not a rhyme or reason that you have to not send a letter. It's totally up to you. Here's the medication reconciliation. I just like you to see some of the stickers on the bottom. So if it just says allergies, it's not going to fly. And so you're going to look at this one. The allergies, drug reactions, and unknown allergies, that needs to be dated every single time they come in. The e-script, it's really important for the nurses to know what is being e-script. Sometimes the doctors do it, they don't even know, especially in the surgery center. They'll just do it, patient goes home. It is really vital. If you are sending them home with a prescription, even though it's e-script, it must be put on this medication reconciliation because you're giving them a new prescription. And what's most important is when is their next dose. So if you don't want them to take something for another 4 hours, you need to write that. If you don't want them to take something till dinner, you need to let them know when the next dose due. Just putting down for pain may not be enough if they were just receiving something for pain. Quality assurance. We can call quality anything you want. You can call it QAPI, you can call it QA, PI, QA, PI, CQI. I think there's a lot of different names. Hospitals certainly have different names. But again, quality is what they're looking for. It could be what's called a risk management program. You can call it your quality program. When I talk about minutes, often people will say, do you do your infection? You can put it all together. Everything that happens in your center is really quality. Okay? So the tags here, we already discussed the quality of discharging with a responsible adult. And the next one is the IFU, instructions for use. If a surveyor walks in and talks to any of your staff that should know how to use a certain product, and they are asked about an IFU and they don't know what that is, you did a poor orientation. Everybody in their department, an IFU is the instructions for use. So I'll just give you a brief example. On one of the surveys, they were using their autoclave and it was validated at 270, and one of their pieces of equipment needed to be at 275. So they ran it at 275, but per the manufacturer's instructions, they did not follow because it was not validated at the right temperature. Okay? You have a glucometer, right? The nurses who are working with a glucometer, they have to know how to do this. They can't say, wait, I'm going to go look it up. And so be sure that the glucometer that you have is still the pamphlet that goes with it, and that the nurses or whomever your staff is using that knows exactly how to use it for cleaning. Okay? Also an important one. Your SDS sheets, this is a lot in quality. Your safety data sheets. Why are these so important and what do you need? If you're doing compounding or any type of hazardous drugs, you would need the SDS sheet for medications. Otherwise, every chemical, liquid, powder in your center must have an SDS sheet. So whoever your materials person is, you really want them to be aware, did this come in with an SDS sheet? No, if not, can I call Henry Schein and can Henry Schein send me one? Of course. Can you go on the internet and just put in the name of your product, an SDS sheet? You certainly can. It is an expectation for everything in your center. Remember I mentioned to you about air fresheners? Make sure you have an SDS sheet. If you have whiteout and you're using at the front desk, make sure you have an SDS sheet. The computer sprayer, the dust buster, you need to have that as well. Okay? You also have curtains that need to be cleaned, and that takes a big one, is they want to know how are you supposed to clean them. Most of the centers say I send it out to my cleaning and they take care of it. You may want to have a little bit better of an answer for that. Okay? And the biggie is annual education. The regulations state that providers and staff are to get the same annual education. Now, whether you choose to do this remotely, whether it's going to be on one of the training programs, there's several out there, whether it's an in-person, on-site, you are required to have this annually. And there are components that are required to be covered. On orientation, the very first day of that person's job, they are required to have an education of life safety. They must know where your doors, where your exits are, where your fire poles, where your fire extinguishers. And you're going to do that the same thing with a rep that's in the back. They have to at least know how to get out. You need to document annual education every year. If for some reason you have to push it a month, you're going to put that in your notes that annual education was on this day and we'll be having it. If you have folks that are per diem, the same information, whether it's reading, whether it's sent out, or video, are required by every single person in your center to have a full annual education. They are really looking at this for the providers as well. New York may have an extra one and say that the physicians have to have infection control training. Whatever your requirements are, make sure it is in the provider's file. And the last one on the quality studies is make them meaningful. I go into a lot of centers and for 3 years, they've been studying hand hygiene. And no offense, but hand hygiene is very important, as infection preventionists will say to you. However, it's not meaningful unless you're doing something with it. So if you were to do hand hygiene, which you're supposed to do, and you had issues, let's say you have a new anesthesia group, that's a wonderful study, because then you would say we have a new group in here. Maybe they aren't following as we expect them to. We're going to write a study. That's a meaningful study because you are putting some data behind it. What are you doing? We're going to train them. We're going to have some information so that we can do a full study. If you have made your benchmark, right, we set a goal in your studies. And if you've met your benchmark for a quarter or whatever your amount of time is, you're going to close that study and let the board know that we close it. Any study can be reopened again, but you don't want to keep them open if you've met your threshold. QA studies also, you may need to change your goal a little bit. So with a goal of 100% for ANSEP, you can't change that. You must hit that 100% threshold, right? You may do a study if you don't, but something like hand hygiene, most of us are putting 90% as our goal because we know it's almost impossible to do 100. So just make sure that your studies mean something to you. A couple of examples. Here's just a couple of things in the annual education of the emergency situation that everybody on their first day should understand. Okay, where your generator, where you're going to turn off your oxygens, and where you're going to meet if you're going to have a lockdown. So I go into centers and I tell everybody this. If you don't understand what someone's asking, it's okay. Don't let any of your staff, or don't you even answer it. Say, I'm not sure. Can you rephrase that for me? So when I walk into a center, sometimes I say to somebody, who's the newest employee? They reluctantly put up their hand. And I say, listen, where's your rally point if you have a disaster? No idea. No idea. I said, okay. And she looked at me. She goes, I guess I could go find out. She went to go ask her DON. When the DON came back, we talked about how she wasn't educated, but she didn't know what a rally point was. All she needed to say was, I don't understand what that means. And I would say, where do you meet if it's a disaster? So make sure your staff answers the questions that they know. They always answer is, I don't know the answer to that, but I know where to find it. Okay, so we want to show all of this in our education. The other part that I'm going to talk about in the infection, these are some of the requirements that you must have as part of your annual education. A couple of the other things in the quality part is benchmarking. Benchmarking is a couple of different things. You can do your own internal benchmarking. So we just talked about monitoring hand hygiene. You're already benchmarking, you know, anesthesia is doing this, or techs are doing this. So where are you with yourselves? And if you're looking to do an external benchmark, ASCA is a great organization. They're a national organization. You can pay to become a member, and they offer benchmarking with outside in your same specialty. Some of the other ones will do the same. So these are just a couple of things that I just want you to know that you can take a look at with QA. A couple more studies. I don't have to go through them, but people say often they can't think of new things, and you really do. Just think about it. The endo center, every one of them is going to be able to tell you they've had repairs. Okay, life safety. Deb covered a lot of this, but these are the hot ones. Documenting your drills. And documenting your drills is when you have a fire drill and you are physically not pulling your pull alarm, you need to call your transmission company and say, I'm going to put on test, we're doing a fire drill. You're going to have your drill. You're going to document your drill, make sure that everybody's aware of what the scenario was. Then you're going to call your company afterwards and you're going to say, we're off of test. What they're going to send you is called a transmission report. And that's what we are looking for to attach to our drill to show that it's happening. Okay? Make sure that if you have different shifts and you have nights and you have weekends, all of those folks are supposed to have at least one fire drill. Okay? And the other part, as Debbie said, is maintaining your equipment, tagging it, getting out, making sure that people know if it's not working. We touched about the emergency stop button, but please understand that the emergency stop buttons are no longer allowed to be on the generator. They must be in a separate area where someone in the center would know that you're truly on generator and you're stopping to turn off the fuel. This is another POC. So if you have any of these holes up in your ceilings, take a look around. This is what they found, and this is the picture they had to send back to AAAHC as an approved plan. A couple other of my favorite pictures. Well, I'll start there. Door propping up. I think everybody should know you have a visitor. The no doors are allowed to be propped open. And speaking of visitor, I often say to somebody, do you overhead page? Do you have a code? They don't know. So when I was in my center, nobody would ever call me Mrs. Sasso. So when Mrs. Sasso was paged overhead, everybody knew we had a visitor. Okay, so you want to have something like that in your center, and it gives your staff a few minutes of a breathing because you don't want to leave your surveyors alone for too long. You also don't want to see any of this. If you have a garbage, which is this, it needs to have a cover in your OR, may not be open. You may not have extension cords and outlets such as this that are not medical grade. So if you do need an extension cord, it must be mounted to the machine or to the wall. It must be biometed, and it must be a medical grade, okay? The other one is if you're going to put a stretcher in front of a fire extinguisher, expect you to get a tag on that one, okay? And holes in the walls becomes very obvious. couple other little things I like to hit: messy janitor's closet, everything's supposed to be up and hung. Eye wash station, where it's supposed to just be eye wash station, you're going to see that there's instruments in there. They do not belong there. The eye wash station, Mike, lovely, they touched upon that earlier. So the infection prevention, these are your tags. We talked about an infection prevention job description and what are your program standards. And so one of the very first surveys walked in, there was a new gal who was an SPD, and we asked her that, and she didn't know what I was talking about. And so again, education, when I said, do you use AMY? Do you use WHO? Do you use CDC? She's like, oh, of course. And she pulled out her AMY book. So you do want your staff to be aware of some of the words that would be asked of them. Hand hygiene, I want you to know that they will watch you, right? A surveyor comes in, they're going to watch a tech come out, see if she changed her gloves, see if the doctor changes gloves, did he touch this and that, okay? And competencies. All of your staff upon hire is to have a competency in their department. So you do want to be sure that they all follow your infection prevention competencies. A couple more of my pictures. Oh yeah, the best one here is this bottom right one where you can see duct tape. I used to have a contest, but now too many of you know, this is a apron. This is a radiologic apron that is used when the doctor goes into the fluoro that they chose, ready, just to keep putting duct tape. We have a physicist who comes out once a year, and the center told me that they hide this one from the physicist. The chair above that one, it was really exciting that if you're allowed, if you want to have fabric or any type of cloth in your center, you must have an IFU, right? That instruction for use that shows you how to clean it. And this center was all prepared and they had an IFU and they were cleaning their fabric chairs just great. A couple other little pictures, no cardboard boxes are to be in your center on the floor. They should be in a delivery area. Anybody unpacking the boxes, we're going to put it on a cart and we're going to roll it back. So there's your calibration. I told you that it doesn't work. So if somebody's going in that room every day and recording a temperature and you happen to do your rounds and this doesn't work, I would ask them a little bit how they're doing their temperature check. Ajax is allowed to be here. Dial's allowed to be here. Just make sure you have those SDS sheets. A couple other things, folding chairs are not allowed to be in any patient area. So if you have a waiting room and you're crowded, or you're doing something for different for COVID, you may not have a folding chair, patient safety. If you have nicked and scratched up floors, if you have rust in certain areas like this, you need to put your best foot forward. You know, they're coming in and they're looking at you, right? You're a patient here. You want to see that we're taking care of, we're new, we're not rusty, and we're not dirty. Oh, if there's this one, sorry about my duplicate, the duct tape. The supplies on this one, we're going to a doctor who's going to be taking those to Haiti, but I didn't know that. They are not labeled. They don't say expired. They don't say anything. So they don't belong there and it would give you a tag. I'm going to talk a little bit about the wrapping. If you have an SPD person, you have your rigid containers doing a great job. If you are packing your wrapped materials, you want to be able to pack them sideways and you do not want to put more than so much weight on top of it. So when you're lifting something up, it should be a light piece on top of it. Otherwise, you're not allowing enough circulation to go through. A little bit of messy draws, tape and gauze should not be exposed. And here's a perfect example of a catheter. So in the yellow bin, the materials came in and somebody folded them, put them in the container because it was a new product. The old product fit in that container. And so what did this person do? Unbeknownst to them, they're compromising. And so you can see on the counter that we try to lay some of these things out and we don't know if we've truly compromised. So be very careful. You can see in the other tray the catheter. So it's very important. If it comes in flat, it needs to be stored flat. Let's talk about rust and chips really quickly because this is really common. I will tell you that there are some ways that you can get around this. The housekeeping, of course, does all the mopping, so you're going to get rust. You can go on Amazon and you can get a set of 4 new caster rollers and replace those. You can try replacing them, of course, and you're going to try your very best to document because none of these pieces of equipment would be considered acceptable. They all have an infection prevention situation around them. The hot one are these pictures right here is gauze and tape. You're going to use gauze and you're going to use tape. Single packages or kept in a Ziploc bag because you're touching the next one and you're compromising it. Best foot forward also means clean draws. Okay, take a look at this one. It's telling me that maybe it's not clean, you're not organized. Same thing with the janitor's closet. Oh, I will tell you on the vents, that's a hot one now. So if you're looking at these dirty vents, you want to take another walk around. Whoever's doing your environmental or your infection preventionist should really take a look at this and talk to your housekeeping. A couple more of the extension cords. There's brushes. We don't reuse these brushes. We're supposed to use one and throw it away. So here's a whole bunch of brushes in a bag being sterilized. And the bottom of this cart is missing a plastic liner. Any cart that is not covered will be required to have a plastic liner on the bottom shelf and on the top shelf. The top shelf would be protecting if your sprinkler came down, and it would protect everything underneath it. And if your janitor is splashing up, and it would protect your bottom shelf. And that's what we're looking for. A couple of little things. If you've got any rips and tears in your vinyl, you can either look for a vinyl repair shop. You might have to replace it. Seeing this recliner with this tape on it is an infection prevention situation, and they were tagged on it. And the cabinet next to that is, you'll see it's open. Anybody notice? It's open and it's locked. Okay. So we don't want to have that either. So this was a pain block, and they unlocked it for the day. And while I was there, I said, wait a minute. So anyway, I want to be sure that somebody's there or it's locked. These are the leadership roles that we talked a little bit about, staffing your place, right? The dialogue with your governing board, and make sure that you have your staffing schedule appropriate. So in a little bit of summation, I want to just give you, this is, what do you really want to do? You want to know what your policies are. Policies and procedures are to be reviewed, that depending upon your policy, might say every 2 years. Your governing board is to look at them. I don't know of anybody's governing board who really reads the policies and procedures. It's our leadership. It's our directors of nursing. It's our pharmacy consultant. It's our infectionist. Give yourself a break and give some chapters to the people in your center. Let them review it. Your nurses who are in pre-op should really look at your surgical services and say, this is what we're doing, or hey, no. Because at the end of the day, it's what your physical policy is. And remember, if you're going to replace a policy, never get rid of your old one. They must stay in archive, and you want to always be able to show when did you put your new policy in place. Okay? The other comments that we get an awful lot is leadership wears too many hats. Many of these centers is one or two people who seem to carry the load. Maybe they don't delegate. Maybe it's small. You're told whatever reason we don't have resources. The accreditation agencies see this, and they're not okay with it because they do not want a director of nursing who's also your administrator be your safety and your HIPAA and your pharmacy and your infection. And when I walk into centers and I hear this, I say, how is that possible? And so this is where we have to speak up and do some advocating, and as much education as I can do for physicians, I will continue to do that. Make sure that you have ticklers in place so you can track your expiration of any of your documents, right? So if you're due to have another H&P, or if you're due to have something, have a tickler file. Anybody's looking for one, you certainly can let me know. I have one that turns color 30 days from expiration. Somebody gave it to a colleague and we share, right? That's what we do, we share. Nerve stimulator, it is required to have one in your pre-op area and one for each OR, okay? That's a mandatory. And take a look at your carts now. You must have a breakaway lock if you have an MH cart. You may not have it locked, whereas you saw the other one was locked. It has to be an emergent situation so you can break it right open. The life safety penetrations, just take a walk around. If there's an outlet falling off of your wall, you're going to see some of that for sure. They're expired medications. This is where we go. First of all, go in your refrigerator when you go to work tomorrow and take a look what's in your refrigerator. 10 to 1, there's usually something expired there, or something from a practice, or maybe even an employee's insulin that doesn't belong in there. We find oftentimes the refrigerator has things that do not belong. And your expired medications, usually, I'll tell you, when I do a mock survey, I go to the back. I put my hand as far back in the shelf, and that's what I'm going to pick up. So if you have somebody walking around, switch it up. Don't have the same person doing that same duty. Environmental rounds should be shared. Expired medications checking should be shared. And the one thing that I can say is if you make a mistake, right? My tagline is we stop, we admit, and we correct. As we shared earlier, it's not going to be punitive unless you did something, you broke a policy or whatever your policy is in your center, but we want to celebrate if we have a near miss because we stopped something, right? We stopped something, yay. What did we do? We want to share with another ship how we stopped that. Maybe the drug was called wrong, or maybe they were placed in a new storage area and we didn't educate everybody and you pulled the wrong one. Celebrate a near miss, because there's no way you don't have one, and it should be celebrated. And surveyors want to know that. They want to know, what are you doing to change things? So when we look at a stop, admit, and correct, we don't expect everything to go perfect. We hear about wrong sites. We hear about unplanned returns, right? These are not our norm. What we want to do is, what can we do to prevent this? Was there more training needed? Was the patient not compliant, and that's why they had an infection? We have to do our due diligence to be sure that the center takes responsibility for what is the center's. And if it's not the center's, right? If the patient got an infection, had nothing to do with their, their surgery, right? So if the patient was there for a breast, and maybe she was gardening, she had a cut on her knee, and she ended up with an infection in her knee and got an antibiotic, that's not yours, okay? That has nothing to do with her breast. So you want to be sure when you're looking at your monthly tracking, which they are requiring. Remember, you have 30 days to close your chart, and each provider is to get that tracking 30 days after, so that they have that responsibility. Was there a surgical site infection? Was there a complication? Was there something that, unbeknownst, did not come out the right way? So having said some of those things, they are the hot topics. Annual education is the most important. I'm a compliance person. I love to teach and educate, and the leaders who want to strive, you got to find a B team. You have to learn how to delegate. Succession planning is so very important. So I want to thank you for this day of education. OSHA was so gracious to offer us this wonderful platform. And my name is Marcy Sasso, compliance consultant, and we will be posting things where you'll be able to get links to the sites, the webinar. Steris mentioned that they will probably be giving a 1 CEU, and you'll contact them. All of this information should be available to you early next week. So I want to thank everybody for your time and appreciation. I know there's questions coming in. I see them popping. And again, we will have those answered. So we so appreciate, give yourself a round of applause for staying put and getting great education. I look forward to our next program together. Take care. Be safe.